Tinea pedis is a dermatophyte fungal infection that primarily affects the feet, most often between the toes or on the soles. The most common causative organism is Trichophyton rubrum, though other dermatophytes like Epidermophyton floccosum can also be involved. This is one of the most prevalent fungal infections worldwide and a frequent reason for dermatological consultations. Tinea pedis has a significant impact on populations globally. Studies indicate that up to 15 to 25% of people may experience this infection at some point in their lives. Key risk factors include excessive sweating and wearing occlusive footwear, warm, humid climates, use of communal showers, pools or locker rooms, and immunocompromised states like diabetes mellitus or HIV. These fungi thrive in moist environments, so feet that remain damp or sweaty are at higher risk. Dermatophytes secrete keratinas, allowing them to invade keratin-rich structures such as the stratum corneum. The moist environment between toes serves as an ideal breeding ground. The ensuing infection causes erythema, scaling, and often intense pruritus. Chronic or recurrent Tinea pedis is common in patients whose immune systems cannot effectively contain or eliminate the infection. Tinea pedis can appear in several distinct ways. Interdigital or toe web type is the most common form. It often starts between the fourth and fifth toes and presents with maceration, scaling, and fissures. Moccasin or chronic hyperkeratotic type presents with diffuse scaling and hyperkeratosis of the soles and lateral edges of the foot. This type is frequently recalcitrant, sometimes requiring systemic treatment. Vesiculobulous or inflammatory type is characterized by vesicles, pustules, or bullae on the sole or instep, and is associated with intense itching and burning. Finally, the ulcerative type is more severe, with ulcerations and secondary infections, seen more often in immunocompromised patients. Patients with Tinea pedis typically present with itchiness, burning, and scaling. On physical exam, you may see maceration and fissuring in web spaces, scaly erythematous plaques on soles or sides, and vesicles or bullae in the inflammatory type. Differential diagnoses to consider include eczema, psoriasis, pitted keratolysis, contact dermatitis, and rarely secondary syphilis. Careful clinical assessment and confirmatory tests are crucial to ensure correct management. Diagnosis hinges on both clinical findings and laboratory confirmation. KOH, potassium hydroxide, preparation. Gently scrape scales from the lesion's active border, place on a slide with 10 to 20% KOH. Heat gently or let sit for 15 to 30 minutes. Microscopic presence of branching hyphae confirms the fungal infection. Fungal culture, Saburo dextrose agar, useful for recalcitrant or atypical cases. Histopathology with PAS, stained skin, biopsy from the lesion's edge. PAS highlights fungal elements for definitive diagnosis. Treatment strategies vary by severity and clinical type. Topical agents are first line for mild to moderate disease. Oral antifungals are reserved for chronic, extensive or refractory infections and in immunocompromised individuals. Supportive measures such as foot hygiene are vital for preventing recurrences. Topical antifungals are often sufficient for mild Tinea pedis. Azoles, such as clotrimazole, miconazole, and ceticonazole, work by inhibiting ergosterol synthesis. These should be applied once or twice daily for 2 to 4 weeks, plus an additional week after resolution. For example, clotrimazole 1% cream is typically used twice daily for 2 to 4 weeks. Allylamines like terbinafine, naftifine, and butanafine inhibit squalene epoxidase. Terbinafine 1% cream can be applied once or twice daily for 1 to 2 weeks, which is usually a shorter duration than azole treatments. Other options include cyclopyroxolamine applied twice daily for 2 to 4 weeks and tolnaftate also applied twice daily for 2 to 4 weeks. It's crucial for patients to apply the medication to both the lesion and the surrounding skin, and to continue treatment even after symptoms improve. Oral antifungals are needed for extensive, chronic or refractory Tinea Pedis, or if there's concomitant nail involvement. The mainstay options include terbinafine, also known as Lamisil, with a dose of 250 milligrams daily for 2 to 4 weeks, and up to 6 weeks in some refractory cases. This requires liver function monitoring in prolonged courses. Itraconazole, or Sporanox, is another option with a dose of 200 milligrams once or twice daily for 2 to 4 weeks. It's important to watch for drug interactions and check liver function. Fluconazole, known as Diflucan, is dosed at 150 milligrams once weekly or 50 milligrams daily for 2 to 6 weeks, depending on severity. It has fewer drug interactions than itraconazole, but hepatic monitoring is still advised. Lastly, Grisafulvan is less commonly used due to longer treatment courses and higher relapse rates. The dose ranges from 500 milligrams to 1 gram daily for 4 to 8 weeks. Let's look at special clinical scenarios. Vesiculobullous Tinea Pedis, a short-course oral antifungal such as terbinafine 250 milligrams per day for 2 to 4 weeks can be effective. Cool compresses or Bureau's solution soaks help to dry out vesicles. Topical steroid antifungal combinations can briefly relieve severe inflammation. For chronic hyperkeratotic or moccasin-type oral agents plus keratolytics like urea or salicylic acid are often required to penetrate thick scaling. In immunocompromised or diabetic patients, high vigilance for bacterial superinfection is crucial. Oral antifungals are often needed, along with strict glycemic control in diabetics. Adjunct treatments include keratolytics such as 12 to 40% urea creams to reduce hyperkeratosis and foot soaks using aluminum acetate or diluted vinegar to dry macerated areas. Prevention is essential to maintain healthy feet and prevent recurrence. Foot hygiene is key. Wash feet daily and dry thoroughly between toes. Use breathable socks and rotate shoes. Protective footwear is important. Wear sandals in communal areas like gym showers or pools. Antifungal powders or sprays can be useful in shoes or on feet if prone to sweating. For long-term maintenance, promptly treat any recurrence and emphasize patient adherence to complete therapy. To wrap up, Tinea Pedis is a common yet potentially persistent infection. Remember these key take-home points. Confirm the diagnosis with KOH prep or culture. Assess severity to decide between topical or systemic therapy. Combine medications with foot care measures for the best outcomes. Monitor for relapse and encourage preventive steps. With thorough evaluation, the right treatment choice and vigilant patient education, Tinea Pedis can be effectively managed and recurrences minimized. Thank you for watching our comprehensive lecture on Tinea Pedis. We hope you found this discussion beneficial for your clinical practice. If you enjoyed this content, please like, share, and subscribe to our channel for more in-depth medical lectures. Your support helps us reach a broader audience and continue providing high-quality educational material. Disclaimer. This lecture is for educational purposes only and should not replace individual clinical judgment. Always refer to your local guidelines and consult standard references as needed. Until next time, keep learning and improving patient care.